Thanks for joining, everyone. We have Dr. Anthony Barrett here with us. Do we have everyone on the line here? I am going to open up Q&A. You're more than welcome to ask questions throughout the question and answer. We'll be answering those on the sidebar.
Welcome, everyone. Sorry for the bit of delay getting started, but I appreciate your time tonight, and hopefully this is educational and provides a lot of great information for those of you interested in the topic of ethnic rhinoplasty. I'll start by telling you a bit about myself. I'm a facial plastic surgeon, double board certified. What does that mean? That means I'm both accredited by the American Academy of Facial Plastic and Reconstructive Surgery, as well as by the American Board of Otolaryngology. To explain that a little bit further and briefly, an otolaryngologist is a fancy term for an ear, nose, and throat surgeon. So ages ago, I was a sinus and facial surgeon. My training then involved into a fellowship in facial plastic surgery, where I dedicated myself exclusively to plastic surgery of the head and neck, including the face. Given the background that I had in the nasal anatomy and the extensive background I had with it, doing a lot of cancer reconstructions, I really fell in love with with the with the art of nasal surgery, and that evolved as things do in life into rhinoplasty. So I've been in practice now for over 13 years, plus my uh, ungodly number of years in training. So I've been doing this for a long time. My surgical practice is exclusively rhinoplasty. I also do perform hair restoration, but as far as my surgical practice is concerned, I only practice rhinoplasty, which is important. I perform over 200 rhinoplasties a year. I think this is a good question to ask your surgeon prior to surgery, is how many rhinoplasties do you perform? Because this is a very complicated surgery, and you don't want to have someone who just dabbles in the procedure. Um, I of which 45% of my rhinoplasties are what we categorize as ethnic rhinoplasty or augmentation rhinoplasty. Um, this comes from a background of uh, not only practicing in Miami, but also doing my training in Chicago as well. So I've really been exposed to a variety of ethnicities in these metropolitan areas that I've been fortunate enough to practice in. As I'm sure you're aware, rhinoplasty is known amongst plastic surgeons to be the most challenging of plastic surgeries. It's a difficult surgery, and that's why it devotes a lot of time, a lot of dedication by your surgeon. And it's also one that even as a surgeon, you're constantly improving and evolving. I lecture at a lot of meetings, both nationally as well as internationally. And I also feel like this helps to really hone my skills, because it allows me to speak on the subject, as well as collaborate with a lot of colleagues who dedicate themselves to the surgery. That being said, very few plastic surgeons perform rhinoplasty, and even fewer at a very high level, because of the complexity of the procedure, and the dedication it takes as a surgeon to provide a benefit and a consistent result for your patients. What I've found through the years is, you know, communication is key. And I really try to even over communicate with my patients. Maybe some of you out there have already had me in consultation. The first thing I try to ascertain from everyone, uh, frankly, just after getting to know you, is what are your goals? And that's the most important thing for me, because everyone has a different goal. And I, may have my own assessment, but I always start with asking my patient specifically, what is it that you're seeking and what your goals are. And if they cannot necessarily verbalize it, it's also good to see inspirational photos, or maybe model photos maybe something that they may want to achieve. That does help me as a surgeon, because it helps me to set proper expectations. Uh, I try to be extremely realistic with the surgery. I'm very confident with what I do, and because of my confidence, I try to set proper expectations for what we can achieve. And through the years, that experience has allowed me to ascertain what can be expected from an outcome. Another thing that I do in both consultations, whether it's in person or over telehealth, is a computerized imaging. I believe it's a tool that we have available that really helps you as a patient, because it helps to kind of show you with your photos, with your own face, what we can realistically achieve. I use the computerized imaging as a means of communication. I don't use it as a sales tool or as a way to kind of overpromise something and show you, yes, this is what we can achieve, or quote unquote the perfect nose. I take what I see on your anatomy, whether it's through a photo review or an in-person consultation, and try to then portray and depict a proper, realistic expectation from the computerized photo imaging. And then I use that as a way of communicating. I encourage patients, typically I email these to patients, and I encourage patients to write me back with any questions or concerns that they may have about the imaging, because obviously imaging is imaging, right? It's not perfect. And I jokingly tell patients, but realistically, that, the nose is not wax. It's not a marble. I'm not chiseling away here. It's human tissues. There's a lot of variables. So I don't like to give, let's say, 3 or 4 different samples of imaging, because that's not realistic to you. It's not. I'm not doing you any favors by telling you, hey, we can choose option A or option B, because it doesn't quite work that way. What I gain from the imaging is just hearing from you as a patient. Can we see this? Can we see that? Would it be possible to do this? Do you think it's realistic to make this a little bit more narrow, or whatnot? And then that's how I use it, because it helps to further communicate between us what would be a realistic expectation from the surgery. Another thing that I emphasize is that I try to show imaging from both the profile and the front. Not a lot of doctors have, or many at all, will show you frontal view imaging, because it's underwhelming. Obviously, these refinements are 3-dimensional refinements, and these are 2-dimensional photos. Even with 3-dimensional imaging, which is available, it's not something that could be realistically portrayed. The frontal view does help to give a good assessment, and in some cases, it's very good, depending on the anatomy and so forth. But it does help to further elaborate or further convey what we could realistically achieve from the front. That being said, I tell patients that the frontal view can be underwhelming, and typically the results are more evident in real life because of the 3-dimensional refinements that we're creating, and something that I'll talk about further along in the talk. So my objective always is to provide you as a patient the safest results, number one, and the best possible outcome, of course, based on your specific anatomy. And for me, I'd rather err on being conservative and giving you a natural result, than I'm not one to push the envelope for my patient's sake. Another thing that I stress, and it's very important to me, is the extension of me, which is my team, my office, my surgical team. My surgical team is wonderful. I've had the same anesthetist for over 12 years in practice. He's wonderful. He works with me in every single one of my cases. My surgical team I'm left-handed, so they're my right hand. They're a great staff, and I've been very fortunate to surround myself by great staff, great surgical technicians, as well as a surgical nurse that we have. I'm the primary and I'm the only surgeon in the operating room. I do 100% of the case from incision to closing. I have a surgical technician and an assistant that hands me instruments, and as well as the anesthetist for the anesthesia portion, and what we call a surgical rotating nurse, as well, who's in the operating room. As you can probably sense from the way I talk, I'm very passionate about this surgery. I love rhinoplasty as hard as it is. I love it because it's the challenge of rhinoplasty that really got me into this field. Like I said, it was an evolution, starting from cancer reconstructive surgeries, and it evolved into my love for plastic surgery, and then more specifically into rhinoplasty. So specifically, let's dive into ethnic rhinoplasty and what we do to um, better assess each patient. Obviously, everyone's anatomy is specific and unique. There are similarities amongst us, but ultimately, everyone's anatomy is unique, and that's how it has to be treated. For instance, the bone height, the length of the bone is different in each patient. The height and width of the bridge, the tip cartilage support. And this is an important point here. We all have various degrees of tip cartilage support. Some can be very poor, and some already have a strong existing tip support. But that's very important, and I'll emphasize this in my later on in my talk, how important supporting the noses. And then what's called the nasolabial angle is different and varies. The nasolabial angle is the angle between the nose and the upper lip. It varies in person to person. Some patients can have a very acute angle to start with, and some have a very obtuse angle. So all these factors have to be considered and taken into consideration with each individual. And then lastly, assessing the nasal base width and flare. Essentially, that's two different things. The nasal base width is what it sounds like, is the distance from end to end of the base of the nose, the bottom part of the nose. And the nostril flare is the curvature or the size of the nostril. Two different things that have to be treated differently. So someone can have a small nasal flare, but a wide base. So, and those will entail different techniques to optimize results for patients, and to give a very natural result. And the most important thing that I have to emphasize is skin thickness. Skin thickness in ethnic rhinoplasty varies from person to person, and it's something that I'll elaborate on in a second. The common concerns that I see in rhinoplasty from the front, our patients will often complain of a wide bridge, which is essentially, there's two components to that. There's what we call the outside, or I should say what we call the lateral, which is the outside component, which is the base of the nasal bones. And then we have the central component, which is the central part of the bridge. Again, I treat those separately because some patients can have a wide bridge, which also is contributed to by a low bridge. You could have a high bridge and yet still have a wide bridge. So all these components have to be factored in, as I refer to them as a central and then an outside aspect when speaking about the bridge. Patients will often complain about a wide tip, or they're bothered by the width, or sometimes they refer to it as a bulbous tip size, which bothers patients. Again, we talked about the nasal base. The nasal base is the distance from end to end, which again is different than the nostril flare. So the nasal base width is something that you could really ascertain from the from the frontal view, whereas the nostril flare is something that we see maybe from the base view itself. Again, two different components, one being the flare, the size of the nostril, the other one being the width of the nasal base. From the profile, patients will often express concerns about the height of their bridge. They feel like their bridge may be too low based on their other facial features, or the roundness of their tip, which goes hand in hand with the appearance of a droopy tip. That arrow that I'm pointing at there is the nasolabial angle. That's the angle, like I mentioned, between the upper lip and the bottom part of the nose. And that could be very acute, which gives the appearance of a droopy tip. And that's due to lack of support in that area that I see. Patients may be missing significant cartilage support or bony support from that angle. And what that does is it's worsened when we smile, obviously, because without that support, the tip will droop even further. Another concern which is expressed is a hidden columella. What that means is that the columella from a direct profile view can't be seen because the nostrils are covering it from the side view. Hidden columella or hooding, as is often referred to as, is because the outside part of the nostrils will hood the columella. So my objective always is to optimize refinements, but at the same time, maintain a natural appearance. That's my number one objective, because I want my patients to walk around confident with a very natural looking result. So how do we attain this? I attain this with structure and support. This is not what we call a reductive surgery. So in order to get the most natural results, I need to provide more structure, more support. And what that would allow for is more definition, which will allow for the concern of and the goals of narrowing without it being a reductive procedure. What I mean by reductive procedure is that oftentimes, we see noses that appear pinched, or the nostrils appear triangulated, and that's due to a reductive approach and without providing for adequate structure and support. And this is due to the skin thickness. So the skin thickness is something that has to be considered, and it depends on each patient will have a different degree of skin thickness. And the skin thickness has to be considered in order to get the best possible results for you as the patient. Like I said, it's the biggest variable that exists between us. So you understand, there are 3 layers to the skin, essentially. There's a lot more, but for the intent of rhinoplasty, I like to explain it as having 3 layers, 2 of which we can control, but one of them we can control. The other 2, I perform techniques to try to control, if that makes any sense. So these 3 layers, for simplicity, are the outer layer, which is that, what we see, right? The outside part. Then it's what we don't see. And this is what's typically the thickest layer, which is what's called the deep dermis layer. That is what varies, and that's what really contributes to skin thickness. It contributes to a sebaciousness of the skin, meaning the porosity, the number of, the pores, the size of the pores, and it contributes to the glands, the oils of the skin. And that's typically varies, and that's typically the thickest layer that we find. The third layer is the fatty or the soft tissue layer, and that can be removed and is addressed at the time of surgery. I often get patients that'll ask for of your nasal tip fat removal. And yes, that is a component of the procedure, and then that does, again, like everything else, that does vary from person to person. But that's not the most important thing, and that's not what's going to give you definition. That's not what's going to give you narrowing. That's not what's going to give you the most natural results. What's going to give you the most natural results is support. And I'll make this analogy. So imagine this is either a thick blanket, or in this case, your skin. The only way to thin that skin is to push into it. And by pushing into it, we're providing that support. And when we provide that support, we can essentially thin the part of the skin that we can't necessarily control. And that's why I really emphasize adequate support in ethnic rhinoplasty. And again, this support comes in 3 dimensions. And this is where things can get a little complicated in their explanation, but it's important to provide 3-dimensional support to give you the most optimal outcomes while at the same time providing for a natural result. So the bridge, the nasal bones, they are reduced in most cases to reduce the width of the base of the bridge. But like I mentioned, importantly, centrally, the bridge may need to be augmented or raised to various degrees. And each person is different, but some patients don't need any augmentation, some need a lot. But what that allows for is that pushing of that central support of the bridge. So you can reduce the width of the nasal bones all you want, but if you don't provide for structure and support along the middle aspect of the bridge, you're not going to get that definition. The tips, same thing. The tip has to be supported, and I remove very little, if any, cartilage for 2 reasons. Number one, functionally, meaning, trying to preserve breathing, which is the primary function of the nose. And secondly, aesthetically, to not provide for a pinched appearance, which to me is the telltale sign of rhinoplasty, of having had a rhinoplasty. So the tip is supported centrally. In my case, what I mean by that is I support it off of the existing cartilage of the nose, which is what's called the septum or the septal cartilage. So I build off of that central support. So it's a natural extension of your existing anatomy, but extending that support into areas where patients may lack support, which is into the tip area. Some patients already have good existing support and some do not. So various degrees of support are added to the tip. What does that mean? Aside from the aesthetic results, that your tip will feel firmer, your nose will feel stronger, it'll feel stiffer after the procedure, which is a good thing. It's something that patients will get used to. In the meantime, you may feel that your smile may feel a little bit funny, as patients will put it, because of, or your upper lip may feel a little bit stiffer. Ultimately, that does go away, that sensation. It becomes kind of like a natural part of you to have essentially a stronger nose. And until you get acclimated, you may have that sensation, particularly, as the swelling goes down. So in order to get, more definition and more support, we really need to bring in cartilage. We need to support centrally, like in this case, and bring in the base of the nose. Another example of a patient, bringing in, supporting the cartilages centrally, bringing in the cartilages from the central support, as well as reducing the width of the base. From the side view, supporting that tip, everyone has a different objective, for their profile view, and that could be tailored. Some patients want a more defined nose, others want a less defined nose. Some of which, we can control, we can't control at all, obviously, because of that variable, like I mentioned, the skin thickness. So some patients with variable skin thickness can get more definition versus others that may have thicker skin. So essentially supporting the tip, lifting it is very important. Providing for more definition, more support, raising the bridge, maintaining an adequate bridge to tip ratio, meaning that again, this also varies between male and female patients. With men, we may want a higher bridge, a straighter bridge, and that with female patients, we may want a lower bridge to provide for a little bit more of a gentle slope to the side view to go, from a more rounded tip, okay, to a more defined projected tip. In order to do that, you notice not only are we supporting the tip, but we're also raising the bridge. So you maintain that ratio between the two. Alar base reductions. Again, these have to be done. My objective with alar base reductions is to take a patient from a rounder or circular appearance to a more oval appearance without what I refer to as triangulating the nostril. So what, again, another, to me, telltale sign of a rhinoplasty is when there's an over aggressive reduction to the base of the nose, and then all of a sudden the nostrils lose their oval shape and they become pointy or pyramidal in shape, which we really want to try to avoid. So we want to reduce the base, reduce the flare of the nostrils, if that's the patient's goal, but at the same time preserve a natural appearance to the base of the nose. Again, and I show this example because a lot of times patients are concerned about the incisions. This patient, and I will, and I make everyone aware of this. 100% of my ethnic rhinoplasty cases are open. I get a lot of concern when patients hear that. For me, it's a non-issue because I used to do closed procedures, but I could not get the results that I'm getting with an open approach. So I stopped doing closed procedures, and I use what's called loop magnification. So I use 2.5 times magnifications under microscopy during these procedures to ensure the best possible closure. This patient had an open approach as well as an alar base reduction. I try to hide the incisions within the creases along the base of the nose and as much as I can within the nostril to avoid exposure of the incisions. So like I mentioned, we're maintaining an oval shape and going from a rounder circular shape to a more oval shape. That's my objective because that will reduce the flare while at the same time maintain an unoperated appearance. And like I mentioned, the reduced visibility of incision by hiding where the incisions are placed. And again, lastly, do not triangulate the nostril. So taking a rounder appearance to a more oval appearance, as in this example with a base reduction, as well as a nostril flare reduction. So I do not use, how do I obtain these results? Particularly in ethnic rhinoplasty, patients may not have sufficient cartilage inside the nose to provide for this structure. So we need cartilage, we need material, right, from somewhere. And I avoid the use of synthetic plastics. I avoid silicone, Gore-Tex, Medpor. These are common implants used in rhinoplasty. I've run the gamut of what I've used over the years. Again, this is a surgery that has evolved, and in order to optimize results for my patients, I'm constantly self-critiquing my skills and self-critiquing how I'm performing procedures to get the best results. But I avoid implants at all costs. So I either use ear cartilage or rib cartilage. Ear cartilage is not great. It's only good in some cases when patients have very good cartilage inside their septum. Rib cartilage and both of these have a risk. Ear cartilage, obviously the incisions from behind the ear. If you don't have a history of keloid formation, it's safe to use. But in some cases, patients may have a history of keloid formation, so we avoid incisions behind the ear. Rib cartilage, which I use as well, and I offer my patients using their own rib. But of course, this has risks associated with it. In addition to having a separate incision in the body and scar, there's the risk of lung of puncturing a lung called a pneumothorax. I've never had that happen, but nonetheless, obviously, it's a risk. So where I've evolved in this is that now I'm using donor banked rib cartilage. So I use donor cadaveric cartilage to provide for the most consistent results and avoid the risks of additional incisions in the body. And I love it. And because I love it, my patients love it too. So it's long been used in orthopedics and oral surgery. Like I said, it avoids additional incisions in the body, avoids the risk of scarring and poor healing, avoids the chest incisions. And what I like about it is that even when I do rib cartilage, everyone's anatomy varies. So sometimes a patient's own rib cartilage is not great. So we have to work with what we have. The nice thing about bank tissue cartilage is that it's very reliable, it's consistent, and and because of that, it gives a great predictability. It's been my go-to now for many years that I've been electing to use it for my patients. So I'll just talk briefly about the postoperative course because it's very important in ethnic rhinoplasty for patients to understand, and it's a process. And I like I said earlier in my earlier slide, I'm committed to your best possible outcome, and that doesn't end at the time of surgery. And importantly, in ethnic rhinoplasty, we need to understand that there's swelling involved. What that is that's literally water retention that happens after any surgery and anywhere in the body. But obviously, when you're having a surgery on your face, on your nose, it becomes aesthetically more obvious to you. The way I describe it is that there's two types of swelling. There's an immediate swelling, which could last, 10 to 14 days. And that's the bruising and swelling that we could find and you will find around the eyes. In some cases, you can use makeup if you wanted to after the cast comes off. Some patients will use it even with the cast on. But essentially, that's something that you need to be aware of that will last for the first 10 to 14 days after the procedure. The second type of swelling is more of a long-term swelling, but that's really more obvious to you as a patient than it is to others. It's not something that others will necessarily notice. What you will notice is that as time passes, meaning months, the nose will become more defined, the skin will appear less swollen, less thick, and you'll get more and more definition. So immediately in surgery, there's an element of swelling. Then it gets worse before it gets better. And the way I describe it is it fluctuates. So it could be according to the time of day. It's literally due to hormonal changes in our body. Obviously, in the mornings, we have a peak of growth hormone and cortisol secretion at night. So when we wake up in the mornings, our rings may feel a little bit tighter. We may have some puffiness under our eyes. That's due to water retention. And just like the nose will appear more swollen in the morning. It may be due to what you ate the night before, salt intake. It doesn't help. It doesn't hurt, but it doesn't help. In women, menstrual cycle, any hormonal changes, anything that causes fluctuations in water retention in the body will create subtle fluctuations in the appearance of swelling of the nose. So as time passes, that goes away. And as I like to describe it, is that it doesn't go away every day. It's not like you wake up Monday and Tuesday, it's better. It may fluctuate up and down. Some days, some weeks may be worse than others, but eventually it goes away. So over time, it goes away, and that varies again from person to person. I like to describe it as about maybe 30% of the swelling will go down after maybe between 4 to 6 months, and then the residual swelling will then slowly go down over the course of a year. I've even had patients after 2 years, come back and say, "Oh wow, what a difference between even a year ago to where I am now." So everyone's a little bit different. Obviously, that's an extreme, but you may even notice changes, over a year, 15 months, and then that's not uncommon. So the follow-up's important. Um, Half my patients are from out of town, so I do have a protocol that I like to follow. If not, we have you send in photos. But the follow-up's important because there are measures. We can't control everything. Obviously, we can't control human tissue, but we can control certain things to a degree. I have you, in most cases, tape the nose at night while you're sleeping only. You would take it off in the morning. I don't find it necessary to be used during the day. And what that does is it helps kind of with the swelling. I feel like it compresses, it holds things, so that way, as the nose swells or wants to swell with the water retention, with the cortisol and growth factor, growth hormone release at night, you have that tape kind of binding things and holding things down. So that I've noted through the years that that's really helped my patients. And again, this has all been experience and trial and error. I found that to be very beneficial to patients and getting them to where they want to be faster. Another thing is the placement of anti-inflammatories. And that has to be done in person. I typically, if you're from out of town, I would, not in all cases, again, this is an individualized process. But in some cases, I place the anti-inflammatory in the nose before you leave town. Then I would have you come back essentially like between 2 to 3 months later. At that point, we may replace some anti-inflammatory, such as cortisone, and that really does help with swelling. Uh, Ultimately, patients will get to where they will get to, but in some cases, cortisone helps to either get you there a little bit quicker or to address certain areas. Again, it's a case by case basis. It's not used in every case. But when it is used, I find it to be an effective means. People often ask me, will I need it? I don't know. It's literally something that I kind of tailor, like I do everything else about the surgery, to each individual. And it's different time frames for everyone. It's even different amounts, or if at all. And like I mentioned, lower salt intake, it helps if you have an event or something, you say I really want my swelling to come down, stick to a low salt diet, less than 2,000 milligrams a day. It really does help because it'll clear out the water from your body and then create more contracture. It's not necessary long term. It's not going to affect your results, but it does help with temporary reductions in swelling. So I'm just going to go, finish up with just some before and after photos to show, goals of achieving a natural result, like I mentioned in men, trying to maintain a higher bridge so that it doesn't appear sloped, which is often a concern in male rhinoplasty, to maintain, a strong appearance to the nose so that it maintains a very natural look to the nose. So in this case, this patient comes in complaining of a bump, but in reality, it's not a bump. From my perspective, it's a low radix and tiptosis, or a low tip. So when you raise the radix and make it even with where the bridge maybe should be to look straight, and then raise the tip just above that, it provides for a straight appearance to the bridge while maintaining a strong masculine appearance in this case. This female patient, she didn't want her nostrils reduced. Her goals were tip refinement and bridge support. So the bridge is elevated in this case. The tip is better projected, like I mentioned earlier, the support to the tip, to maintain, again, a very natural look. She did not want her nostrils addressed. So a nasal base reduction was not performed in this case. It was primarily a case to address the bridge and her concerns for her low bridge, as well as some better tip narrowing. Again, not to provide a pinched appearance, but essentially enhancing this young woman's nose as it is. So as you can see, to get that, what we did for the profile view was to slightly raise the bridge in her case, of course, not as much as the male patient earlier, and to elevate and better define the tip from the side view so it doesn't appear as rounded or as bulbous. This patient again wanted nostril reduction and flare reduction, so the nostrils were reduced. The bridge was brought in, and she was given better tip support, better tip definition to overall reduce the width of her nose and give it a little bit better definition in the tip and bridge area. So again, in her case, the bridge and the tip is elevated and the tip is better projected to provide for those results from the frontal view. A male patient, again, his primary concerns were the reduction of the width of the nose, to reduce the width of the bridge, as well as the width of the base of the nose. So in this case, the nasal bones were significantly reduced in their width, as well as the bridge was better structurally supported centrally. The alar base was reduced and the nostril flare was reduced to provide for a natural appearing reduction, which better conforms with the rest of his facial features. And that's something that I always take into consideration, is assessing the patient from literally forehead to chin, cheek to cheek, to be able to provide for something that appears very natural within the patient's framework. And this again is bridge supported from the side view and as well as his tip to provide for those results from the frontal view. This is a reduction, showing a reduction of his nostrils, again preserving an oval shaped appearance to the nostrils so they don't appear as wide or as flat. And again, these are all done with an open approach and a nostril incision, which again, the incisions heal extremely well. And I'll finish up with this patient. Again, her goals were the reduction of the base of her nose, the reduction of the flare of her nostrils. So two separate things, again, reducing the nostril flare, as well as reducing the base of the width of the base. Her nostrils were asymmetric to begin with, so I tried to help improve the symmetry. I tell patients that improving nostril symmetry is unpredictable. It's very, very difficult because there's too many variables that contribute to nostril shape and width. It's not just due to the cartilages, it's due to the skin, the soft, what we call the soft tissues, as well as the cartilages and where the nostrils insert. So there's many variables of which a lot of them we cannot control. But in this case, we were able to, give more symmetry to the nostrils. And again, in her case, she wanted more bridge definition, not only with the reduction of the width of the bridge, but again, to provide more central support to the bridge, which will in turn allow for a more narrowed appearance and more structured appearance to the nose. And as you can see that from the profile view as well, the bridge is better defined, elevated, her radix is not as low, and her tip is less rounded and more defined from the side view. So thank you. I'll open it up now to, there's been some questions throughout the talk, and I'll briefly address these.
Yeah, Dr. Bear,
Yeah.
the first question is, are the computerized images, do they reflect the end results? And is it after a year or immediately?
Great question. No, the computerized images are definitely not immediate results. Our objective is to get to that end result, which is, whether it's a year and a half, but that's the objective over the long-term end results. They're not the immediate results. Like I mentioned, the swelling will fluctuate. It's a variable in every person. It's a bit unpredictable, but the computerized images represent long-term results. My anesthesia is done by a CRNA, Rick Gonzalez, who's, like I mentioned, I spoke about in my talk. Rick is wonderful. For any one of you who have had the privilege to meet him, I've used him for every single one of my cases. I've used in the years ago, I used an MD, and it makes no difference for my patients' well-being and safety, because Rick has 30 years of experience. He reaches out to every single patient and does a thorough assessment before the surgery. He's even done procedures on my own family. And he's someone that I use on a daily basis, and I feel extremely comfortable with him to perform all my cases. I've never dealt with empty nose syndrome. Empty nose syndrome, I try to avoid turbinates and turbinate reduction. Again, like I mentioned, my background is in otolaryngology as an ear, nose, and throat doctor. So I avoid um, the turbinates, which is what results in empty nose syndrome. Um, Exercising, I like to wait 3 weeks after exercising, before exercising, I should say. The way I like to explain it is after 2 weeks, you could resume like a light cardio routine. And then after 3 weeks, you could resume a normal workout routine. Your nose will get more swollen. That's normal. That's fine. You're not ruining your results. It's just part of the healing process. I like for patients to get back into their lives as soon as possible because getting back into your life helps with the recovery overall. One of the things that I do have patients avoid is glasses or sunglasses on the nose for 6 to 8 weeks following the procedure. It's easy to use.
Francis, did you have a question?
Yes, can you hear me?
Yes.
Okay, doctor, I recently visited you and you sent me the pictures, and I'm quite happy with the graphic images, and it looks little elevated from the profile view. My question is, you talked about the elevation. So this elevation will be high in the male patients compared to the female patients, because you said certain areas will be elevated, not the complete
Yeah.
bridge. But my question is, will it be always more in I mean, high elevation in case of
No,
male
it's tailored to
compared
the patient and their goals, but typically male patients want a stronger bridge. But of course, it's individualized. I try not to slope um, the bridge in male patients to give a more natural result.
so it depends on the patient's request also, right? If they don't want that much, um, I mean, elevation needed, but not that much, you can still bring
Right.
it, right?
Understanding though that elevation is what gives you more narrowing
Support. Yeah,
and support from the
right.
frontal view. So
Got it.
I tried to explain it with that slide of that support from the side view is what in turn gives more narrowing and definition from the frontal view. When you
Okay.
spring back the nose, when you set back the bridge, now you're creating the propensity for more widening from the front.
Okay. Thanks.
What are the chances that a nose will collapse? It's extremely unlikely. I mean, that's more prevalent in a reductive surgery, like I was referring to earlier. Um, I've never had a nose collapse. It's something that with adequate structure and support, you know, should be avoided. It's something that I have done surgeries on patients whose noses have uh, collapsed, but that was typically from a reductive surgery who then sustained trauma or some other factor that contributed to that. For all the patients at the before and afters, I had to, no, not necessarily. I've a patient asked, were all the before and after photos the patients had donor implants? No, no, not necessarily. It varies, like I said, person to person. So not all patients necessarily had donor implants. Can rhinoplasty cause permanent dark circles under the eyes? Can rhinoplasty cause permanent dark circles under the eyes? Also, interventions in the past, no rhinoplasty. Will this affect the rhinoplasty that I plan to have? These are great questions. Patients can get temporary darkness under the eyes, especially patients that have darker skin pigmentation. What that is, it's called hemosiderin. So basically, when our blood cells have iron in them, right, and copper, and when the blood cells are ruptured or lysed because of bruising, that could go into our skin. It goes away over time. I've had patients that have had darkening under the eyes, but over time, your body clears it because it's not something that sits in your skin. Our skin, as you know, or as many of you may know, sheds and evolves, and so over time, I've seen those dark circles go away completely. It doesn't happen in every single case in the sense that not everyone gets darker circles. Some patients are more at risk for it, and those that do get it, eventually the dark circles go away. Turbinate reduction does not affect rhinoplasty. The only thing that does affect rhinoplasty is septoplasty, if a previous septoplasty was performed. So it's important to know if a turbinate reduction was done solely or if it was done in combination with a septoplasty. The reason I say that is because, like I mentioned, the septoplasty is that strong cartilage support that we build off of and we may use at the time of surgery. So it helps to have an intact septum. It's not necessary. It involves a little bit more of it's a more involved procedure if a septoplasty was performed. But the turbinates themselves do not affect rhinoplasty at all. Have any of your patients asked for corrective work because they were not satisfied the first time? I've done a review of my patients, and this is a cosmetic procedure. So obviously that's a risk of surgery. A review of my database shows that it ranges between 5 to 7% will ask for a secondary procedure. And that's treated on a case-by-case basis, of course, because there are some things that patients, and again, that's why I try to over communicate and try to set proper expectations, because there are some goals that are just not attainable and they're not realistic. So I try to be very upfront and very clear about that before the procedure. That's a part of the reason why I have such a low touch-up rate. Another part of the reason is because of the structural approach to the procedure. So we really shouldn't see, other than the reduction in swelling of the skin, changes. Sometimes scar tissue settles in that we do have to address. So sometimes the skin itself may not heal entirely like we want to see it. And of course, that has to be addressed as well. There are doctors that tell you, oh, you may need a secondary, and it's true. It's cosmetic surgery. Obviously, it's the nature of the beast, if you will. That being said, whenever I walk into that operating room, my primary objective is this is it. This is it for you as a patient. I'm there to give you the best possible outcomes. It'll take me 2.5, 3 hours, whatever it takes, to get you the best possible outcome long term. And that's my number one objective with each one of these cases. I'm a stickler for trying to get things as good as possible. My staff knows me for that. And that being said, though, it's human tissue. Like I said, it's not marble, so things can come up. Fortunately, my revision rate is between 5 to 7%.
We're just going to unmute Francis. He had one more question.
Yes, doctor. Actually, I was typing. I would like to ask about the scarring. Since you said it's an open procedure, there is an obvious scarring after the procedure. So will it go away by time? That's my first question. And if it does not, so do we necessarily need a laser treatment for complete scarring removal?
Laser treatments can help. Typically, it's not needed in any central incision. Um, I've had some patients that have had laser treatments to the incisions along the outside.
Okay, but that will also go away by time, right? Even I don't need laser necessarily, right?
I'm sorry, what was that?
I mean, even if there are visible scars, that might go away by time, right? I may not
Oh,
necessarily need the
correct. No,
laser.
no, yeah. No, my the the nose and the scarring takes time to heal, so it tends to go away over time.
Okay.
Scars need to mature.
So will that also be the same number of years that you mentioned, like 1 to 2 years, doctor?
6 months for 6 to 12
Okay.
months for scar maturity.
Okay, got it.
Just a couple other questions
Yeah.
here.
Is there some patients I love how when patients ask me for their concerns, you fix so keep up the great work. Okay, thank you very much. Will out-of-town patients be able to stay in the clinic? Great question. My nurse is available. We don't have an overnight facility, but we have a nurse available for out-of-town patients who need someone with them. We only require you to have someone with you the night after the procedure because of the anesthesia itself. My nurse is available to stay with you if you don't have someone to accompany you. Is there anything like an objectively good-looking nose, regardless of ethnicity? Why the focus on ethnic? There are some ethnically ambiguous people who just want to look good. Yes, this is a term. Ethnic rhinoplasty is just an encompassing term to use for patients other than a Caucasian patients. Yeah, I do agree that there are an objective that we try to obtain, but again, this was more focused on what's augmentation rhinoplasty and patients that have thicker skin and maybe poor bridge and tip support. The other uh, uh, types of rhinoplasty are for hump reductions and tip support. So a different objective. A great question. Is virtual consultation enough before planning to have the procedure? Or is it important to see the nose? Okay, so for like I mentioned, half my patient base is from out of town. So I have I've developed the experience to do this. I always do a virtual consultation prior the to seeing you in person. I would essentially see you, do a virtual consultation, have you send in photos where I would perform a computerized rendering of those photos that you send in. We have patient examples of how those photos are done. And then I always meet with everyone prior to the procedure. Of course, in person, I do have to do a physical exam and an intranasal examination, as well as take my own photos, which I take a million of for any of you who have already seen me. Um, so I typically will have the patient come in, ideally 1 or 2 days before the surgery to do an adequate physical examination and a preoperative visit. How many days do I need to stay there for 1 week, for 7 days? I have, let's say your surgery's on a Friday, you would leave the following Friday is fine, or Monday to Monday as an example. And then if you are from out of town, I would see you either in person the day before. So maybe a total of 8 days. Someone asked the question, the how much is the initial consultations? Um, consultations are it's $100 consultation fee. which gets applied to any surgical procedures. All right, I think that pretty much wraps it up. I don't want to take any more of your time. These are great questions, and I really appreciate everyone's time this evening, and I hope this was informative for everyone that joined. Thank you.
Thanks, Dr. Barrett.
Thank you, Stacey.
Have a great evening.
Bye-bye.